Hi guys, welcome back. This is Dr. Deepak Marwa, and today we shall be talking about multiple myeloma, which is also called as a plasma cell dysuria. Let's study what is the problem in this particular patient, which would be obviously because of the overproduction of the light chains of antibodies. Now, all of you are aware of the fact that the antibodies would be having a heavy chain component and a light chain component. The heavy chain component would be related to antibodies, that is G, A, M, D, E. That's the standard ones that we study. And when it comes to the light chain, then the components which are to be remembered are kappa, K, kappa, and then lambda. Those are the Roman numerals that we use. And the problem in this patient is that there is an overproduction of the light chains of these patients, and all these antibodies that are produced with overproduction of the light chains are defective antibodies. So one of the leading reasons why patients of multiple myeloma would die would be obviously due to infections, and most of the time it is either a pneumonia or it is a pyelonephritis which will contribute to mortality in this particular individual. The number one cause of death in multiple myeloma is not to be answered as renal failure. The leading cause of death is infection. I said a waste of all the resources that the body has. And if you look at the image here, I've shown you a PET CT. They had simply given an image like this and they said, what is the investigation shown? So that would be a combination of PET and CT scan. Now, why I'm saying it's a PET CT, because anatomical aspects can also be picked up. Like you can see the outline of the kidneys, you can see the outline of the lungs of the patient. So it is a combination of anatomical evaluation with functional evaluation. We use radioactive 18-fluorodeoxyglucose in PET scan, but this combination would help you know the functional damage as well as the anatomical damage. You can also notice that some of the dye is getting excreted in the bladder and some is concentrated in the brain tissue. So why the brain is black and the bladder area is black is obviously because of the dye getting excreted and being picked up by the brain, because brain uses glucose and kidney is excreting the dye. But at the same time, you can also notice some focal active areas. And where are those focal active areas? They're located in the ribs, they were located in the pelvis of the patient, and that's very characteristic. No, pelvic involvement, vertebral involvement, and rib involvement is a feature of multiple myeloma, which explains bone pain, which is one of the common symptoms that is encountered in patients of multiple myeloma. Now, do we have light chains in urine of a normal person? Like I usually put up a question, do you have proteins in urine of a normal person? Yes. How much? Less than 150. Mark my words, not 30 milligram. That's albumin, guys. Normal protein in our body is less than 150 milligram proteins. And normally, do you have light chains in urine of a normal individual? That the normal light chains in the urine per day, yes, are present. Shockingly are present. Normal light chain excretion in the urine of a normal individual is less than 10 milligram per day, and in multiple myeloma obviously this excretion would be double, triple increased, and nowadays therefore we are using a serum light chain assay and a urinary light chain assay for diagnosis of multiple myeloma, as I'll explain to you in the reworked video. Now, once we are having this overproduction of the light chains in the patient, what also is going to happen in the patient is that there will be hyperviscosity developing in the patient, and that hyperviscosity will explain the symptoms of headache and visual impairment and ataxia that can be appreciated by these patients. You will see me using the word M component again and again in the discussion of multiple myeloma. So I would just like to clarify that for multiple myeloma, M component to appear, that is the light chains to appear, the tumor load should be at least more than 10⁻⁹ tumor cells, which will cause an excessive amount of paraproteins. Now, how would you identify these paraproteins? One of the tests that is available to identify the paraproteins is immunoelectrophoresis. And the second technique that is available is immunofixation. And because they can be image-based questions are the same, so I'll just show you the image so that you can be more familiar with this. For immunoelectrophoresis, if you look at this report, you can obviously see the albumin component, then is obviously the alpha-1 globulin component. One of the important alpha-1 proteins is alpha-1 antitrypsin, which is produced by the liver. Alpha-2 again comes from the liver, ceruloplasmin, that binds to copper. Beta is obviously transferrin, and then are obviously the immunoglobulins, the GAMD and the heavy and the light chains. Now, when you look at the electrophoresis report of a patient of multiple myeloma, you will see this very spike present that is either called as the M spike. Why it is called called as the M spike is not because it gives a shape of an alphabet M, but primarily because it is monoclonal. It is only one kind of cells, the CD138 positive monoclonal cells, which are multiplying again and are producing defective antibodies, which is responsible for this. This appearance is also called as church spire. Like on the top of a church, there would be this spike present. So church spire appearance is also used to describe the M spike and is one of the integral diagnostic components of multiple myeloma. Then a second, this is electrophoresis. And the second technique that they can ask you is immunofixation. In immunofixation, you can see that we will first obviously check for the serum proteins, and in these patients, in the serum proteins, different fragments will separate out. Then it will also tell you that which antibody is the one, and even which antibody subtype is being produced, like either it's kappa variety or the gamma variety. So like in multiple myeloma, the most common defective antibody produced is immunoglobulin G, and the subtype of that is kappa or lambda. That depends, but the most common defective antibody produces immunoglobulin G. So by doing immunofixation, we can even tell which antibody is being overproduced in multiple myeloma, which is mostly immunoglobulin G, and the subtype of that kappa or lambda also has to be specified in the diagnosis of the patient. So let's come back to what's actually going to happen to the patient in multiple myeloma. Once we are going to have the overproduction of the light chains in the patient, the M component will be having a high tumor load, which needs to be identified. One of the important diagnostic criteria for multiple myeloma is obviously a bone marrow plasma cytosis of more than 10%. There should obviously be a presence of a serum or a urine M component, and obviously myeloma defining events, which I'll just explain to you. So three things are must for diagnosis of multiple myeloma that I'll write down subsequently also, but three things are a bone marrow plasma cytosis of 10%, a urinary or a serum M protein component, either serum electrophoresis or urine electrophoresis, and myeloma defining events, which I'll explain to you. Let us now understand from the pathology perspective, why do you have multiple myeloma? That is one, and second, what is the profile of the patient? One of the important causes for this would be radiation exposure, which would be veterans of World War II, and second is mentioned is petroleum products. Now, which are the occupations where petroleum products can be exposed is like woodworkers or farm workers. That is where petrochemicals can be used or pesticides can be used. So he has mentioned this very interesting thing that woodworkers, farm workers are predisposed to multiple myeloma due to exposure to petroleum products, and was not given in the older editions of the books. Then is obviously the chromosomal reasons behind it. From the chromosomal perspective, one of the important ones that you need to remember is hyperdiploidy. Then after hyperdiploidy, the chromosomal reason to be remembered would be 13q14, which you read even for retinoblastoma. Then is chromosomal translocation 11:14, chromosomal translocation 4:14, and you will notice that 1414 number is coming very frequently. Then would be 1416. Before I add more, I want to remind you the fact that, like you know, for Burkitt's lymphoma, the number 8 in chromosomal translocation is repeated again, that is 28, then 814 and 822. These are the chromosomal translocations that you read for Burkitt's lymphoma. Here the number 14 has come up a couple of times. Another one to be remembered for multiple myeloma would be deletion related to chromosome 17p. Then there is defect in chromosome 1 also. That is either a 1q amplification. A bit time twisting data, but should be worth the effort that I want you to remember, or could be a 1q deletion. So radiation, petroleum products, and these chromosomal associations are responsible for development of multiple myeloma. Let us now look at what will be the manifestations of this particular patient from pathological perspective, so that we can finally remember the clinical features of the disease. One of the biggest problem that is encountered in this condition would be that the myeloma cells will be responsible for excess production of interleukin 6. This is going to cause the activation of the osteoclasts, whereas the osteoblastic activity would remain normal in the patient. This will explain serum alkaline phosphatase to be normal in this patient, but osteoclastic activity would cause development of lytic bone lesions in the patient, which explains the bone pain as one of the most common symptom in patients of multiple myeloma. So the question will begin by geriatric age patient presenting with low backache. I've already explained to you old man with low backache, 70-80 years of age, carcinoma prostate is also to be kept in mind, but in this case there would be some pointers given, like for example, because the bone is destroyed, the serum calcium of this individual would be increased and serum alkaline phosphatase of this patient will anyway be normal because the osteoblastic activity is normal in this particular individual. So hypercalcemia is one hint that tells you that he's not talking about a carcinoma prostate in most of the cases. Now the increased calcium will also start causing damage to the kidney. Renal failure is an integral presentation of these patients, which will explain the uremia component that comes in these patients. If he says what is the leading cause for renal failure, it is hypercalcemia. But it is not only the renal failure due to hypercalcemia, even amyloidosis of the AL variety develops in this condition, which will cause kidney infiltration and will cause myeloma kidney, which can cause damage. Infections, as I told you right in the beginning, are also common in this condition. It is not only pneumonia, it is pyelonephritis, which will damage the kidney parenchyma. And because the patient is having bone pain, so patient will be having NSAID usage on a regular basis to curb the bone pain, and NSAIDs affect prostaglandins, which affect in turn the filtration of the kidney. So therefore in these patients there could be 4 reasons for renal failure, including abuse of painkillers, but the leading cause is obviously the hypercalcemia component. I am worried about this patient because hyperviscosity will occur. This hyperviscosity will explain the headache of the patient, the visual problems of the patient, the ataxia component of the patient. How do you define hyperviscosity? So one, you should know that blood is thicker than water. Well, that's a saying, no, blood is thicker than water. So today I'm telling you that plasma is thicker than water. How many times? So plasma is 1.8 times the viscosity of water. I've written 1.8x. The viscosity of water is the viscosity of plasma in our body. In multiple myeloma, or to say the word hyperviscosity, he says in Harrison that the plasma value should be 4x. That is 4 times the value of that of water. So if you are saying the word hyperviscosity, plasma viscosity is 4 times, and this explains the sluggish circulation present in these patients. And the sluggish circulation can also explain not only the kidney damage, that is tubules would be having ischemia. You see, tubules are deeper in the kidney, so they would suffer from ischemia, but even the venous circulation is affected. So headache, vertigo, ataxia, these are the standard manifestations of the patient. The next statement of mine might look very surprising to you, but that is what happens. Hypogammaglobulinemia is the norm in patients of multiple myeloma. Though you are producing antibodies, they're all defective. So ultimately the ability of the patient to fight the infections is going to be very pathetic. 2 infections are common in these patients, that would be lung infection, pneumonia, and pyelonephritis. And usually the organism for pneumonia is pneumococcus, that is Streptococcus pneumoniae, the traditional one. So why I have written this and I have said this earlier is that if he says leading infection in the patient, then it would be pneumonia, that is more common than the pyelonephritis component. Because this is a chronic disease, there would be a normocytic normochromic anemia developing in a patient. Another reason for anemia of these patients is infiltration of the bone marrow of the patient by the myeloma cells. I mean, myeloma cells will cause replacement of the normal bone marrow. So the normoblasts are replaced, which results in normocytic normochromic anemia, where the RBC size and I would say the amount of hemoglobin inside them is normal, but then the amount wise the RBC count is significantly reduced. Remember that not only do these patients have bony lytic lesions which begin with alphabet B, but they also have bleeding. Do not neglect the bleeding part in the MCQ part. Why do multiple myeloma patients have bleeding? One, I can say that the megakaryoblast will also not get time and space to multiply because the entire bone marrow is taken by the myeloma cells. Second, he says a very interesting fact, antibody coated platelets. Two very interesting statements which are given in the new edition of Harrison is, one, he has mentioned that light chains in the urine are less than 10 and higher than that indicates multiple myeloma. Very interesting statement. And second is antibody coated platelets in this condition, which highlights the, I would say, the malfunction of the platelets and a prolonged bleeding time in patients of multiple myeloma. Plus obviously these patients would be having amyloidosis, which can contribute to manifestations like carpal tunnel syndrome. So these are the pathological reasons why patients come to you. So we can just correlate this with the clinical aspects. I'll just use a different ink to highlight that. The most common symptom of this patient would be bone pain. The disease would start like in a 60-year-old man. Bone pain is the number one symptom. Usually would start in the vertebra and can be dangerous enough to cause a compressive myelopathy. This will require hospitalization in a patient because this old man, he has developed a fracture of his spine, due to which there is a sudden onset paraplegia, and then a bladder and a bowel incontinence might develop in this particular patient, especially if the lumbosacral nerve roots are involved in the patient. And obviously he was earlier suffering from bone pain in the pelvis, also was taking painkillers for this. Skull, guys, is the last one to be involved, and it is rather the vertebra which is the first one to be involved in the patient. So bone pain is one of the reasons. Then the patient would obviously be having hypercalcemia. The hypercalcemia component predisposes the patient to lethargy. It predisposes the patient to fatigue, and I'm worried about calcium because if calcium goes up, it can cause damage to heart. Remember, I've taught you calcium more than 13 can even contribute to systolic arrest. So heart failure manifestations can be developing in the patient. Due to the renal failure in this particular individual, uremic manifestations will occur. Usually the creatinine of this patient can go up to a value of 2 mg/% or even higher. The hyperviscosity of this patient will explain the headache of this patient, the dizziness of the patient, the vertigo of the patient. The inner ear circulation is also sluggish. So therefore neurological symptoms would also be present. His pallor component is going to keep on increasing on a progressive basis. There could be bleeding manifestations in the form of epistaxis. There could be melena in the patient. There could be even hematochezia occurring in the patient. Then pain in the hand will occur due to amyloidosis, that is carpal tunnel syndrome, which would be pretty debilitating for the patient. Carpal tunnel syndrome, you all know, can be seen even with hypothyroidism. Information technology professionals or IT section, they anyway have carpal tunnel. Pregnancy can be associated with carpal tunnel. Acromegaly can be associated with carpal tunnel syndrome, and amyloidosis anyway is a cause of carpal tunnel syndrome in a patient, and the median nerve is the one that is involved in the patient. So mononeuropathy and median nerve involvement will occur. So these are the usual manifestations that we encounter in patients of multiple myeloma, and I've tried to correlate that with pathology. Now guys, there is an interesting thing that is coming up, which is that we traditionally read that CRAB is a feature of multiple myeloma, no doubt about it. Where CRAB, C would stand for hypercalcemia, which is due to the lytic bone lesions that I've explained to you, and the hypercalcemia would be more than 11 mg/%. R would stand for obviously the renal failure developing in the patient, and because of this the uremia component will come up. Therefore the serum creatinine of this patient will be elevated and can be more than 2 mg/%. A would stand for the anemia component developing in the patient. The B would stand for two things, that is bleeding as well as bony lytic lesions. Traditional is obviously bony lytic lesions, that is very easy and anybody can tell, but even then the bleeding component can also be present in these patients. What I want to tell you is that CRAB features are must for diagnosis of multiple myeloma, but what he has said is that you don't need all of them. You see, in the current edition of Harrison 20th, he has mentioned that any one of these present in a patient with plasmacytosis is sufficient for diagnosis of multiple myeloma. So the main reason why I have reworked the diagram or reworked the entire videos to highlight the fact to you that you don't have to have all these manifestations simultaneously to say that okay, it is multiple myeloma, because our objective is early diagnosis. So he's used the word myeloma like events, which means that any of these manifestations present, calcium more than 11, renal failure exhibiting creatinine more than 2, development of normocytic, normochronic or monolytic lesions. If any one of these are present in a patient with obviously present of a M spike and a presence of a bone marrow plasma cytosis is sufficient for diagnosis of patients of multiple myeloma. Let us now look at the workup for diagnosis of multiple myeloma. One of the important tests to be done for diagnosis of this condition is complete blood count that will reveal that the ESR of the patient is grossly elevated. In fact, in this condition, even the WBC count will be significantly elevated in case the patient is having a plasma cell leukemia. Earlier, he used to give a percentage for plasma cell leukemia, but now he has given absolute amount. He says that if in the blood of the patient, the plasma cell count is more than 2000 cells per microliter, then it is suggestive of diagnosis of plasma cell leukemia. When you will check for the albumin globulin ratio of this particular individual, it would be grossly distorted because globulin in the blood of this patient will be very significantly changed. In fact, the gamma globulin is the main fraction which is increased in this patient due to overproduction of immunoglobulin G or A or M or whatever. Maybe it most of the time would be immunoglobulin G. You have to take care of the kidneys of the patient, so KFT revealing a serum creatinine or more than 2 is definitely a myeloma defining event. Because the patient is having lytic lesions all over, so a PET CT would be done in this patient. Do not answer a bone scan, answer a PET CT or a MRI for evaluation of the damage to the axial skeleton of this patient. When you do a coagulogram of this condition, the bleeding time will always be increased. Why? Because there is a platelets which are coated by antibodies, so they're always going to malfunction. The next test to be done for this condition is anion gap. Remember the fact that the anion gap of this patient is significantly reduced. Now listen to that very carefully. Why is the anion gap reduced in the patient? You see, multiple myeloma is a condition where paraproteins in the blood, that is the M component, is increased. Paraproteins are cations. Cations would mean positively charged proteins. They are increased in the body of the patient. One of the basic functions of human body is to maintain electroneutrality. So to maintain the electroneutrality, the kidneys will come in, because kidneys will now start reabsorbing increased amount of chloride from the urine, and therefore the chloride values in the blood of the person of multiple myeloma will tend to rise. Now, because you look at the formula for anion gap, the formula for anion gap is positive charges subtracted from the negative charges in the body of this patient. What will happen in this condition is the positive charge that we take into consideration is obviously sodium, but the negative charge that we take into consideration is chloride and bicarbonate. And because in this medical condition, to maintain the electroneutrality, to balance the cations of the paraproteins, chloride values are increasing. So mathematics now, negative charges are increasing, so the anion gap will reduce in the patient. If you have any issues with the mathematics here, please let me know, because I have seen people having issues with anion gap, and I do get messages which I have tried to explain this to you, but I think the mathematics is very clear. I'll try to do this again. You see, the cations, paraproteins are increased. The paraproteins are not included in the positive side of anion gap. It is sodium mainly that is to be considered, or hydrogen ions which are to be considered, but not definitely the paraproteins. Because the positive charges are more, the kidney will reabsorb the negative ions, that is chloride, and if the serum chloride tends to increase, then the mathematical value of anion gap will definitely reduce. So reduced anion gap will be encountered in these patients. If he says what is the screening test for diagnosis of this patient, the screening test for multiple myeloma would be answered as serum and urinary electrophoresis. We can do either of the two. It would be a good idea to do a serum electrophoresis of the patient, and after doing a serum electrophoresis in the patient, this next thing to be done is also simultaneously a immunofixation, which I was showing to you earlier, because I not only need to know that there is an increase in the M component of the gamma globulin, but I also want to know which antibody and what subtype of the light chain of the antibody is being overproduced in the patient. After doing an electrophoresis with immunofixation, we also do a flow cytometry in the patient. Flow cytometry will also reveal the diagnosis, because the cells which are present here are CD138 positive cells. In fact, that's one of the statements that I want you to remember. If he says what is the investigational choice for this condition, the investigational choice for this condition is obviously a bone marrow biopsy, and bone marrow biopsy should be revealing more than 10% plasma cells. Please be very clear that he has correctly mentioned this word. Bone marrow biopsy showing more than 10% cells with presence of myeloma like events is useful for diagnosis. Some people have said that in pathology it is 60%. Look at my next slide, I'll tell you when it is 60%. Otherwise, for multiple myeloma, the primary answer to be given is what I have said here. That is presence of M component in the plasma with myeloma like events, and bone marrow biopsy showing more than 10% is sufficient for diagnosis. You can even do a bone marrow aspiration in the patient, not an issue with it. In the urine of this particular individual, we will also be checking for values of beta-2 microglobulin. The reason why we check for urinary microglobulin is that this is the best test for prognosis of patients of multiple myeloma. Beta-2 microglobulin is a prognostic marker. Because amyloidosis will occur in the patient, so we will also have to do a abdominal fat pad biopsy. I repeat, this is what Harrison has said. For amyloidosis, it is not a renal biopsy or a gingival biopsy. It is an abdominal fat pad biopsy, which would be done in the patient because there is a carpal tunnel syndrome manifestation. There is a mononeuropathy manifestation in the patient. So these are some baseline investigations to be done in this patient. And yes, I also need to do FISH, a fluorescent in situ hybridization, to pick up the chromosomal translocations that were responsible, like 4, 14, 11, 14 that I was talking about. The last test to be written for this patient by the protocol is serum light chain assay. This is specially advantageous for diagnosis of this condition. In fact, the diagnostic importance of this test has increased because we can actually measure the light chain amount, and therefore we can know that the patient is having a plasma cell dysuria. Let us now see what a pathologist will see under a slide for bone marrow aspiration or biopsy, core biopsy specimen of this patient. One of the highlights of the plasma cells would be that they would be having an intensely basophilic cytoplasm, as you can see. And the second feature that you can notice is some areas the blueness is relatively lesser, which is written as perinuclear clearing. So these are two features that would be noticed in myeloma cells, giant cells. In fact, you can notice some of them might be having these inclusions also, which would be called as Russell bodies, which are due to the accumulation of the immunoglobulin G component in the patient. A second feature from pathology perspective is that in the nucleus especially, the chromatin, which is in a higher zoom, you will notice that the chromatin will be in the periphery of the cell, and the term that they use is called as a clock face pattern of nuclear chromatin, which is like 3 o'clock, 6 o'clock, 9 o'clock. That's where the chromatin in the periphery of the nucleus is located. I've given you two images which I could actually recollect from my students. One is obviously the standard hematoxylin and eosin stain, and the second one is obviously the right and the GIMSA stain. So both images from histopathology perspective should be very clear to you. For the myeloma cells, and even in the myeloma cells, you can notice in some of them there are obviously these inclusions which are called as Russell bodies. These are basically the light chains which have accumulated. Then obviously much more magnified view, it looks like the cell is having acne, so the cell is also called as a Mott cell. As I said, these are immunoglobulin light chain antibodies accumulation inside the cell, and in some of the cells even inside the nucleus there is accumulation of these antibodies, that is light chains. So the term that they use in pathology is called as Dutcher body. So let's just quickly recall the pathological features here. Intensely basophilic cytoplasm, Russell bodies, Mott cells, and clock face chromatin appearance is what you basically need to remember from the pathological perspective. In the workup of this patient, if you do a X-ray skull, the X-ray skull of this particular individual will reveal a raindrop configuration. You can notice multiple lytic lesions, but the raindrop configuration of lytic lesions in the skull of the patient is a feature. And if he says what is the best way to identify the disease process in the patient, then it is a PET CT or a MRI that will tell you the whole expanse of the disease, because you can actually see whichever area and bone areas which are basically getting involved in the patient. So imaging modality of choice for this condition, imaging modality of choice for multiple myeloma is a PET CT followed by MRI, whichever is available. And lytic lesions in X-ray skull are a very late presentation of this particular individual. Let's look at the latest criteria for multiple myeloma, because that's the one that I basically want you to remember. He says the fact which I've been trying to tell you, that whole of the crab end organ damage. He says whole of the crab is not mandatory. Any one of these could be present. So in the new classification is used the word myeloma defining events in the patient. The definition criteria remain more or less the same. Bone marrow clonal plasma cells having a 10% or more expanse in the bone marrow with presence of any of the following myeloma defining events in the patient. What are the myeloma defining events? If the calcium of the patient is more than 11 mg%, or renal failure telling us creatinine is more than 2, anemia is defined as hemoglobin less than 10, and lytic lesions which are seen. So crab is very much there, right? Crab is very much there. It is just that any one of these present is referred as a myeloma defining events. And let's look at the new things that he has said. The new things he has said is that even if crab is not there, you can diagnose the patient if clonal bone marrow plasma cells are more than 60%. So remember my words now. If crab is not present, you see guys, our objective is early diagnosis. Even if, why do you want to wait for kidney to get involved? Why do you want to wait for the calcium to get elevated? He says that suppose calcium of the patient is normal is 9 to 11, no? So let me say it is 11.2. You're not going to say that it's going to be 13. Then I'm going to say that, you know, you are having lytic lesions or multiple myeloma, and lytic lesions will obviously take some time to appear. So he says that if crab is not there and only in the bone marrow more than 60% cells are present, it could be taken as a myeloma defining event in a patient and can be used for diagnosis of this particular patient. Then is serum free light chain. That is what I was saying. Serum free light chain ratio more than 100, which could be kappa or lambda depending on whichever is being overproduced. And then a lesion on a MRI which is found to be more than 5 millimeters. So 3 new things have been added, which are, I'll repeat again, bone marrow showing more than 60% of the plasma cells in the absence of crab, or presence of serum light chain assay more than 100, or focal lesions on MRI, even if it is one present, size more than 5 millimeter is sufficient for diagnosis of multiple myeloma. Now suppose in a multiple choice question he gives you a situation that the plasma cells of the bone marrow of the patient are less than 10%. He gives you a situation that the M component in the plasma of the patient is less than 30 grams per liter or 3 grams per deciliter. And he also mentions that in the patient there is no evidence of myeloma-like events. Like instead of saying crab, the only difference is myeloma-like events. So there is no evidence of myeloma-like events in a patient. Then in these circumstances, the diagnosis of the patient should be given as MGUS, that is monoclonal gammopathy of unknown significance. But suppose in the patient 2 of these features are present, which I'll write here. Like for example, if he says that the patient is having plasma cells in the bone marrow which are more than 10%, he says that the M component of the patient is more than 30 gram per liter, and there is no evidence of myeloma-like events in a patient, then the term that you will use for the patient would be called as smoldering myeloma. And obviously if all the 3 things are present in the patient, then you will call it multiple myeloma. And if plasma cells in the bone marrow are in excess of 2000 myeloma cells in the blood circulation, then you will consider it to be plasma cell leukemia. For prognosis of the patient, you will have to use serum beta-2 microglobulin and serum albumin values. So 2 things have to be present together, and higher is the value, more is the prognosis bad for the patient. That is, we can classify the staging of this. So the olden Salmon-Dury stage is not used. We are currently using 2 parameters, serum beta-2 microglobulin and serum albumin, for management of the patient. And for treatment of this patient, the drugs which are used are obviously dexamethasone. Do not answer melphalan. 30% response rate only. So what we are using is dexamethasone, we are using lenalidomide, and we are using a proteasome inhibitor, that is bortezomib, for the patient. Most of the time with these combinations we are having a 100% response rate. After this we will decide whether we want to continue with the drug treatment or whether the patient is transplant compatible. If the patient is transplant compatible, look at the words that I'm writing here. Normally we give allogenic bone marrow transplantation, but here we are going in for a autologous stem cell transplantation in the patient. So this is one of the rare hematological disorders where autologous, that is self bone marrow transplantation, would be done in the patient. What I want you to remember from this disease is mainly some of the pathological slides that I've incorporated, which they have asked, which cause of which I've reworked some of the information in the lecture. And second is obviously the aspects of crab, like whole of crab is not now necessary for diagnosis. Any one of them could be called as myeloma-like events. And an update is that over and above the myeloma-like events in the patient, these features have been added, which are serum free light chain assay present, or MRI lesion of more than 5 mm, even if a solitary lesion, and clonal bone marrow plasma cells more than 60%. If the CRAB features are not present, can be help in diagnosis. Any one of these present is sufficient for diagnosis of the patient. So this is a topic, guys, that you basically need to remember. Thank you so much for listening.